I am happy to introduce Audrey Ruple. She is the Assistant Professor of Health Epidemiology at Purdue. She is a diplomat of the American College of Veterinary Preventive Medicine and focuses on figuring out why infectious diseases spread and why cancer occurs, with the ultimate goal of understanding what we can do to prevent diseases from affecting both animals and people. She spends her free time raising small humans and farming. Today she will present a talk titled
You can do it.
Chikungunya, West Nile, and Zika, oh my, emerging zoonotic viruses and the concept of One Health. Please take a moment to silence all electronic devices, but feel free to tweet using the hashtag #DawnOrDoom. Thank you and enjoy.
Thank you for that introduction, Ben. And just for my own curiosity, is there anyone in the room that doesn't recognize the name of one of these viruses up here? Brave souls, thank you for being willing to admit that. We're going to talk about pandemic diseases today. And this term refers to diseases that cross geographic borders, so across entire continents or even around the world. And a pandemic disease that I'm sure we've all heard of is bubonic plague or Black Death. So this was a pandemic disease that spread from Asia across Europe in the mid-1300s. So this disease claimed over 100 million lives. It took the world population about 200 years to recover. Some other impacts of this disease on society included impacts on politics, religion, and obviously arts and the humanities. Another pandemic disease you've probably heard of was the flu epidemic of 1918, commonly referred to as Spanish flu, which is not where it originated. It actually originated here in the United States. But 100 years ago, our world was at war, and troop movements around the world actually spread this virus literally to the farthest reaches of the earth. So even remote islands in the Pacific and in the Arctic, we saw cases of flu. But this disease traveled in waves. So the first wave of the pandemic hit in the spring of 1918. And that wave of the flu looked a lot like what our seasonal flu looks like in today's times. So we had a great magnitude of people that got sick, but the people that typically died were the elderly and the infirm. But just a few months later, in the fall of 1918, there was a second wave of flu that covered the earth. This second wave of flu was the one that was most deadly. And this is the one where we had the young, previously healthy individuals that were dying of flu. Lots of preventive measures were put into place. It was recognized that flu was being spread through respiratory droplets. So these flu masks were having to be worn, and this was something that was being mandated. Failure to do so obviously came at great risk. But despite those preventions that were put into place during that second wave, there was still a third wave of flu that came in the spring of 1919. We had even further death and loss during that third wave, but lesser in magnitude than during the second wave. But across all three waves of this pandemic, we ended up losing another 100 million people in the world. But it only took 2 years to lose 100 million people this time. Many of the women who were pregnant during the time of the flu pandemic lost children, lost their fetuses. There was an increase in fetal death. But children that were able to make it to birth struggled throughout their lifetimes. So they were smaller in stature than the cohorts of children born before or after the flu pandemic. They struggled with weight gain. They were less likely to graduate from high school. They had, on average, across both genders, only 10.5 years of education total in the course of their lifetime. They were at an increased risk of becoming physically disabled and needing welfare support in order to survive. And despite these mass impacts that we've seen with historical examples of pandemic, it's widely believed that we're not ready for the next pandemic. And if we were to have a pandemic of the same magnitude as the flu pandemic hit in today's time, we'd be looking at a loss of over 400 million people, and maybe even in a faster time period than just 2 years. And so we don't know when that pandemic is going to happen, but we do know that it's likely to be zoonotic in origin. Zoonotic meaning that it's spreading from an animal species into the human population. We also know that it's likely to be an animal species that is a wildlife, not a domesticated animal that will be the harbinger of this disease. And we know this because of the basics of disease transmission. we're going to take this really simplified example of a population, right? So each of these dots is an individual that is uninfected with disease, but susceptible to disease. But they're not all equally susceptible to disease. So this population is going to have different vaccination status. Some of these individuals might be under-vaccinated. Some of these individuals might be malnourished. And some of these individuals might have other health impacts that would make them more susceptible for disease, such as being diagnosed with an autoimmune disorder. But then when we take an infected individual and we put them in the middle of this population, what we see is a fairly predictable spread of disease. And the disease will continue to spread until there's a mass called the critical community size is achieved. What that means is that once the population of susceptible individuals falls below a certain number, the disease spread's going to stop because there's just not that many susceptible individuals left in the population. The reason that we know that our next epidemic is going to be zoonotic is because that concept of critical community size is completely moot when you surround this population with animals that might be already infected or capable of being infected with a zoonotic disease. So when the disease spills over from this animal population to the human population, the humans are then able to amplify and spread disease amongst each other as well. This is just a narrative of this. So virus goes into animal population, spills over to human, and then human-to-human transmission can occur. We've been seeing more and more of these spillover events occur over the last 30 years or so. And that's due for a lot of different reasons, and I'm just going to touch on a couple of them during this talk. So one of the reasons that we're seeing an increased number of spillover events is because of climate change. So as the Earth's temperature has warmed, we've also seen changes in the vector distribution. So we're seeing mosquitoes in areas that we've never seen mosquitoes before. We're seeing ticks in areas that have never seen ticks before. And those vectors are bringing diseases with them. And these greater geographical ranges of diseases are then bringing these diseases in contact with susceptible hosts. We're also changing the way that we're using our land. This is an example from, can anybody guess? Have we seen this picture before? This is from Brazil. So what's happened in this picture is we've had rainforest that's been deforested in order to turn that previous rainforest land into cattle grazing areas. This does two things. One is that these large areas of rainforest are being made smaller by deforestation. So all of the wildlife is getting into a smaller and smaller geographical area and therefore spreading disease amongst the wildlife. But then we're also pushing the boundaries of humans and our domesticated animals up to what was previously wild zones. So we're having more and more disease transmission happening at these types of artificial habitats that we've created. We're also a more globalized society, and this is clearly something of our own making. So 100 years ago, I told you that troop movements moved the virus around the world. Well, that was on boats, right? Now we can get to the other side of the earth in less than a day, and that's even including the time that you're sitting around and waiting for connecting flights. So this is looking at the last 30 years at zoonotic disease trends, and what we're seeing is that we've seen more and more zoonotic disease events occurring around the world, and we're seeing this happen with different types of diseases. So these are bacterial, viral, and also some parasitic diseases that are replicated in this heat map. But really for the rest of this talk, I'm going to focus on viral diseases. And the main reason for that is because I can guarantee you that our next epidemic disease next pandemic disease will be viral in origin. I'm going to use dengue virus as an example. All right, so we're going to start here in the 40s and 50s. You can see dengue virus is in a very tiny bit of geographic region in the world from the 40s and 50s. Not a whole lot of spread through the 60s, starting to see some spread in the 70s across Asia and into Central America. By the 80s, we see dengue virus all the way up to North America and down into Australia. In the 90s, we're seeing a much wider geographic spread. And then this is fairly contemporary, so this is 2000 to 2013. And what we're seeing in this is not just that we have a very large geographic spread of dengue virus, but it's also that we've gone from only having one type of dengue virus reported to 4. So the virus is actually mutating, and we're able to detect different types of virus in different parts of the world. And so again, going back to that disease transmission, what we see is that once the virus gets out of this sylvatic cycle, so out of the animals and into the humans, it starts to have its own cycle, where humans then become their own reservoir for disease. Now, this is going to start to look pretty familiar, because I'm going to go through a couple of different viruses. Everybody's heard of West Nile virus, right? All right. So West Nile virus was first identified in Uganda in 1937. For those of you who are geographically challenged, there's a little dot. It's on the east coast of Africa. So it took from 1937 for West Nile virus to get from the east coast of Africa to 1999 for it to get to the east coast of the United States. So West Nile virus was first identified in the Bronx, both in humans and animals simultaneously. So this was both an MD and a DVM working together, identified West Nile virus, and it only took 3 years for West Nile virus to get from the east coast of the United States to the west coast of the United States. So 60 years to get here, 3 years to cross the entire continent. This is the virus transmission cycle for West Nile virus. So this wildlife amplifier for West Nile virus is birds. It can go from mosquitoes into horses, considered a dead-end horse. That's funny. Dead-end host, and also into humans. So once West Nile virus is in humans, something called vertical transmission can occur. It's typically women can transmit West Nile virus to their children, either during pregnancy, at the time of childbirth, or even through breastfeeding. So again, it becomes something that we start to cycle within our own population. Chikungunya, Tanzania, 1952. Again, for those of you unfamiliar, that's the southern neighbor to Uganda. So first identified 1952. Worldwide outbreaks don't start for 50 years, not until the year 2000. This is the spread of chikungunya in 2015. Global spread. Same type of a cycle. So this is the sylvatic cycle from wildlife into humans, and then once into the humans, we have what's called an urban cycle of chikungunya. And Zika, as talked about by Dr. Widmar this morning. So again, first identified in Uganda in 1947. Nobody heard a word about it until 2015, right? So gets to South America in 2015. This is what the spread worldwide looked like at the beginning of 2016. And then this is just looking at the end of 2016, just in the Americas, and we see pretty cohesive penetration across the entire Americas. I suspect that this is lack of reporting here. Basically, Zika was everywhere by the end of 2016. So another one takes 60 years to even show up at all, and then once we see it, it's spread very quickly. As Dr. Widmar was talking about this morning, this is something that we're still at high risk for it, but we've stopped talking about it. Doesn't make it not there. So I've been talking about this geographic spread of these viruses, and I'm going to talk a little bit about the symptoms and what these viruses actually look like in human populations. So I think most people are pretty familiar with West Nile virus and what the symptomology looks like, because this is something that actually got some media coverage, especially in the 1990s, but then also in 2012 when we had another big outbreak of West Nile virus in the US. So what's interesting is 80% of the people that have this virus don't even recognize that they have this virus. Only 20% of people report having symptoms. And the symptoms that are reported are actually pretty mild symptoms. They're typically reporting headaches, fever, and skin rash. Those are kind of the big ones. This is what that skin rash looks like in West Nile virus. Kind of tell exactly where the mosquito bit them, and then they end up with this target type of rash around the mosquito bite. Similarly, Chikungunya virus actually replicates in the skin, so at the site of the bite. It looks a little different. Looks like more of a disseminated rash rather than a focal rash. But other symptoms of chikungunya are kind of the same: fever, headaches, maybe a little bit of body ache as well. Very similar to what dengue virus looks like in a human population. Fever, joint pain, headaches, rash. We all know what this is, right? Zika virus. So everybody heard about Zika virus and what the symptoms look like in children that are infected in utero, right? So they have microcephaly, so it's this collapsed skull, this smaller skull size. These children have cognitive, sensory, and motor skill problems. They also have some problems with limited range of motion in their limbs. But what we didn't talk that much about are what Zika really looks like in adult populations. It's not surprisingly, right? It's looking like the same thing. So we've got 80% of people don't even recognize they have the disease, 20% are symptomatic. Of those ones that are symptomatic, we see fever, rash, and joint pain. Kind of getting the picture, right? But a worldwide pandemic of rash doesn't actually sound that scary. But what I failed to mention was that this is what first wave of pandemic is going to look like. We're going to see an episode of infectious disease where there's very few people that are even recognizing they're sick, even though we're getting pretty good penetration of virus across a large geographical region. What I failed to mention is what the second wave of pandemic might look like. So this is something that we've identified in dengue. Now, the reason I started with dengue is because it's the one that's been spreading longer. We've seen more active spreading with dengue virus for many decades, and this is something that we're just now beginning to understand why this happens, but it's something we've recognized for quite a while. It's that the first time you get dengue isn't really the issue. It's the second time you get dengue that you end up having this second wave effect. So the first time you get dengue, you kind of get this mild symptoms, again, that fever and rash, feeling like flu-like symptoms. The second time you get dengue virus, you get something called dengue hemorrhagic fever. You guys are all familiar with that term, right? Hemorrhagic fever. Make you think of any other diseases? Ebola, exactly. So Ebola is a hemorrhagic fever. This is the same type of thing. So we're talking, and I did decide not to add any photos to this talk, knowing that there was going to be a wide array of background of people with different backgrounds in their audience. But we're talking bleeding from the eyes, bleeding under the skin, really severe abdominal pain, vomiting, and death. So in order for us to really stop that second wave of pandemic from occurring, we're going to have to figure out a way to identify first wave of pandemic disease, which is clearly going to be difficult to do because people don't even recognize that they're sick. But I would posit that we can do it through using the concept of One Health. Now, for those of you that are Team Doom, One Health is going to be this overlap of animal disease and human disease in our shared environment. But for those of you that are Team Dawn, this overlap is actually going to be that healthy place where healthy people and healthy animals live together in a healthy environment. And so this is looking at disease transmission across all of those quadrants. So we have environment, we've got vector, we have humans, and we have animals, both domestic and wildlife, and companion animals as well. And we already have surveillance system in place across all of these different realms, not just locally and nationally, but also internationally. And by surveillance system, I mean just a cohesive monitoring system that are in place. So some of the monitoring systems that we have for food animals are typically based out of USDA at a national level. And so we're looking for zoonotic diseases within those food production type of animals. We also have local, national, and international groups that are looking at zoonotic diseases within companion animals. We have groups that are looking in environments and wildlife and even in vectors. We have a really robust vector surveillance system where we actually go out and capture mosquitoes and then check for virus inside of mosquitoes. And then within humans, we have this national notifiable disease surveillance system that this is actually something that feeds into the World Health Organization. So this national system actually feeds into the world system, and it alerts for disease that is occurring within human populations. Now, what's the problem with these surveillance systems when it comes to pandemic disease? Yeah? They rely on reported data, so if there's someone who's not reporting data for whatever reason, like not going to like a doctor. Right. So they rely on reported data, right? So when does that data get reported? Right. And if 80% of people are in that first wave that aren't even going to the doctor because they don't even recognize that they're being sick, We're never going to get to the point that we're going to identify first wave of disease using the current surveillance systems that we have in place. So what's the solution? Anybody have any ideas? I have an idea. Completely borrowed this slide from the Ideas Festival. So what if we designed a surveillance technique using existing technology where we could identify first wave disease of pandemic proportion? Anybody have any ideas? I have an idea. This is what it starts with. These wearable electronic devices, right? So fitness trackers and smartwatches. I read recently that we're up to about 60% of the US population is currently wearing one of these devices. And this isn't just the millennials that are wearing them. These are marketed to kids as young as 4. I also read recently that this is something that is being marketed for use in elderly populations because they're a really good reminder system for when to take medications. But I don't know if any of you have heard about this Stanford heart study, Apple heart study. Does anybody in the room heard about this study? Okay, one person. Okay, good. Well, I'm excited to talk about this. So this is something, so Stanford University partnered with Apple Watch. They designed a surveillance system using the heart monitor inside of Apple Watches to check for arrhythmias. They weren't so much interested in the arrhythmias, they were interested in stroke. But this became a surveillance method where they were looking for arrhythmias within population. They were tracking information, and they did get people's consent to track their own information. But it also, if you had an arrhythmia and if it was detected, the watch would then alert you. Arrhythmia has been reported. We've noticed this. If it was something that started to be tracked over time or something that was severe enough, you would get a notification that said, call 911. So it was a surveillance system that was working in both directions. So it was this bidirectional surveillance system that was put into watches. So what could we do to create a surveillance system that would catch that first wave of pandemic disease? What's something we could track? Does it have to be something that all those viruses had in common? Body temperature. Guess what? We already have this technology. So infrared body temperature techniques and thermometers, this is something that's been on the market for quite a long time. That upper right, that's a product that is produced for people to not wake your baby, but be able to keep track of their temperature. It's a Bluetooth-enabled temperature tracking device. This one on the wrist, this was developed at University of Illinois. It's a skin plantable, they call it, skin plantable device that can stay on for months, and Bluetooth-enabled can track your body temperature over time. I'm suspecting most people would not want to get a tattooed body temperature sensor on their body, but putting on the watch that they're putting on every day, maybe not such a big deal. So my thought is, we take these smart devices and we put in temperature tracking devices, we can actually come up with a biosecurity health hazard alert system that actually goes bidirectionally, right? So because these are activity monitors, we'd be able to tell if the temperature was increasing in absence of increased activity, right? So there's a slight elevation, because these are typically low-grade fevers. We're talking about a fever of like 100, not 103, not the kind of fever that most people go to the doctor for, but a slight elevation in body temperature without an increase in activity level that could then alert to a public health monitoring system. But the other side of it is that we could alert the user. Notice an elevation in your temperature. Please go home. Don't go to work, and definitely don't go to the shopping mall or the grocery store. So maybe then in a population, what we might see when we get that first individual one is we say, okay, we've got one individual that's located. But the other thing that these devices have are GPS sensing units, right? So we could look within a geographical region, if we start to see increased elevation in temperatures in other individuals, that might actually be an indication that we're seeing spread of disease. And then maybe that biosecurity device and that alert doesn't just go off to those that are impacted, but it starts to alert those around them, and then those around them, and those around them. And basically creating a protective zone around those people that may very well be harboring a disease that they're not even aware that they have. So I would speculate that that's the way that we can stop disease from reaching pandemic proportions in this day and age. I'd love to take any questions that you might have. When? Mm-hmm.
Just like in terms of if somebody just, like has the flu or something, but a lot of people can get the flu. So I'm just wondering what your idea is on how to differentiate between something that's really serious.
Yeah, so the question is about how to differentiate whether or not it's serious. And the reality is that we wouldn't actually want to differentiate at all. So this type of surveillance is called syndromic surveillance. So we're looking just at the syndrome and not at the underlying cause. And the reality is that for that one individual, it could be anything, right? It could just be a transitory virus. It might not be something of pandemic proportion. What would really alert at the public health level is when we start to see that spreading within a population. Now, maybe it is flu, and maybe it's not a 1918 flu, although last year I did have the flu, this last flu season. It felt like a 1918 flu to me on an individual level. But even just alerting on the individual level, hey, you might be getting ill, is one thing. But really the alert that would come into play for pandemic purposes is about looking for spread and patterns within the population. Another question? Got one at the back. Sorry, I'll get you next.
Hi. So you referred to the alerting of the people as creating a safety bubble. As a behaviorist, what if it becomes a panic bubble? Or like we saw with Ebola, where people who had Ebola symptoms actually hid from health providers. So the phone or watch tells you, oh, you're starting to spike a fever, so you pull that thing off as fast as you can and hide in your apartment after going to the grocery store and the mall and everywhere else. So what kind of things could you do to maybe prevent that, or maybe not alert people? Or what do you think about that sort of scenario?
So I really like that you brought that up, Courtney, and thank you for that question. So I think that the behavior piece is something that always has to be taken into account. And that is certainly something that I think, mass panic is certainly something that could arise. Could. It could also be that those exact same people that would panic might panic in such a way that they actually prevent further spread of disease, right, by removing themselves from the rest of society. And I suspect that there would have to be an educational piece that goes both directions with that. One of the things that our local public health providers do is they do door-to-door visits. So rather than having it be a ding through a watch, it might very well be that you end up with someone at your door, and hopefully not in that ET fashion where the whole house gets covered and the people show up in the white suits. But I think that there has to be a balance between the possibility of public hysteria and the prevention of disease spread. So obviously it's something that needs to be taken into account. We had a question up here.
Yes. So I know you said that it's people who are unaware of that they have the virus or the illness, but I think you're forgetting people who do not have the money to go and see a healthcare provider.
Right.
Or people who don't have the money to afford a watch that's going to be biohazard. So in those instances, that's a problem.
Sure, so the question was about people not being aware that they have illness, but then bringing up that there is actually an intersectionality to this, and that sometimes it's not that people aren't aware that they're sick, but it's that they can't afford to go see a doctor, which is certainly something that is problematic. Now, the funny thing is that I understand that this might seem like something where you'd have overlap in the same ways, and that the people that are the very same people that can't afford to go to the doctor are also the very same people that will not have a watch or a wearable device. But there's actually a lot of interventions that are happening in the public school systems in the US that actually involve wearable technologies, where students that are the least economically secure are actually being given wearable technologies for a vast array of different reasons. Data tracking issues aside, quite often the wearable device is actually the least part of that barrier. Dennis?
Sure. So, and this has been brought up in several different talks, but anytime you have this new technology that you bring together to help prevent the dawn side of things, you always have the doom side of the scenarios where companies try to take advantage of said technologies. So let's say we implement these wearable devices and insurance companies start charging exorbitant rates for, say, people who are unhealthy. don't go to the doctor quite often. So how do we prevent those types of scenarios from happening?
So a question about the prevention of these types of data being used against the individual. So this tracking of information that's being used for greater good than not being used in a negative way against the individual. Is that a correct way of kind of encapsulating that? So this is something that obviously is pretty close to the hearts of those of us that work here at Purdue, and that our biometric information is now being supplied to a third-party healthcare provider, right? So this is something that we're all quite familiar with. I do think that there are pieces of, or elements of these data, like as far as the tracking of steps and activity and those kinds of things that would have to be privacy protected. And I would think that those pieces that, like especially for the public health perspective, I think that what if we're really interested in is about increase in temperature, then we need to really limit and restrict the data access to exactly what we're actually interested in, and only use activity monitoring data to then mitigate what that temperature is. But I think it's really important that we talk about privacy, whether that be real privacy or perceived privacy, at the very forefront of developing these types of surveillance systems. Because I do think that there comes a point where we do have to think about greater good, at which point I would argue some of those personal protections might be worth sacrificing, with an asterisk, might be worth sacrificing in order to look at greater good. Go ahead.
Who is the kind of governing body of the data? Is it like the CDC that would get this? Do they provide the watches? How are you, like how would that be kind of laid out?
Yeah, so CDC is actually currently in charge of much of the data, especially about zoonotic disease spread in particular in the United States. And then they're in charge of feeding that information up to the World Health Organization. Now, they are good stewards of those data, and they do a really good job of protecting those data at an individual level. So again, there is some data privacy that's built in. Now, currently, CDC is not using wearable device technology as part of their surveillance systems. We're just using our public health laboratory networks. That's what we're using the basis of our surveillance system at. So I would suspect that if we were to kind of take this step back and look for surveillance on that front wave of pandemic, then that'd be something that would feed into a CDC system.
And would it be going through, like, they'd have to go through the individual companies of the wearable devices to obtain that data?
Well, so Stanford did actually work with Apple specifically. And so they had specific privacy protections written just with that one company. So at this point, there's a lot of different makers of wearable fitness devices on the market. And I don't know what the infrastructure will look like. I'm definitely on the biology side of it, more so than on the technology side of it. But I do think that there is a possibility that we could build a data frame network that would be able to feed into from multiple different sources, kind of across different branding and those kinds of issues. Wait, Gert? And get them help. I absolutely love that you were able to pull a telemedicine question into this talk. So the question was about concerns about taking someone that might be potentially infected, and then taking them into a larger population like a hospital population for testing. And would telemedicine be something that would be a usable and viable technique in that situation? And telemedicine meaning medicine at a distance. So either through a teleprompter type of screen, or something that we're seeing more and more likely is we're actually seeing public health nurses that are going out in the field, and then they're communicating with a doctor either through Skype or FaceTime or some other sort of technology platform. Yes, I think this would be a perfect example of a place where we might be able to use telemedicine. I think in general, though, most hospitals are set up, even the most basic, least populated types of hospitals are set up with different types of strategies to how to deal with infectious diseases. And so people with potential infectious diseases at the time that they're admitted to a hospital typically go into a quarantine situation, and it's not something where they would necessarily then expose vast numbers of people just by being at a hospital. But I think that, yes, it would be a great place for telemedicine. Any more questions? Another one?
So for the temp, that can be very manipulated to like people.
Mm-hmm.
Now they're like hack into your own watch and like manipulate your temp, or like even place your temp in like a cooler, like someone else's arm, and like rather than having it on your arm to like show whether it's actual temps. How would that be?
So the question was about variations in temperature between individuals. Let me answer that first question first. So same thing with heart rates. Like everybody's base heart rate is different, and their base rhythm is different. And that was actually one of the strengths of this Stanford study, was that that surveillance was based upon the individual. So it wasn't just about like what arrhythmias might look like in a generalized population, but it was about your heart rate has looked like this for 3 weeks, and all of a sudden it has changed. And it's the same thing with base temperature. You're right, everybody does have a different base temperature, but it would be looking at increases in those from that baseline on an individual level. I'm not really sure about hacking. I suspect that there could be.
The manipulation, like someone can take off their watch and put it on, like if a mother had her child that was ill, decided she doesn't want her child to be taken away from her, she could put her watch, like her child's watch, on herself.
Sure.
To change the time.
So if somebody had switched watches from herself to somebody else, I think that then we could always put in some sort of an alerting system that then you can ask those questions, right? We've noticed an elevation in your temperature. Have you changed locations? Have you put your watch on somebody else? I think that there's ways to do some fact checking and verifying of that information. One more?
So I think that the integration of One Health and engineering design is super interesting. And my question relates to kind of the future of that. So what would be your hope in, like what would One Health look like in an engineering classroom and engineering technology development design space?
What would One Health look like in an engineering or technology or design space? I don't really know where you'd put the limits on that. So everything that I do comes from this perspective of One Health. So I'm trained as a veterinarian, but I'm also a PhD cancer biologist. And so everything that I do really does look at health in this kind of multidimensional way, where I look at health in animals and in humans, but also the environmental impacts of that. So I would suspect, and I guess you asked specifically about education and how, and oh, man, can you give me a more specific example?
Like what is something that you wish every Purdue engineer understood about One Health?
Oh my gosh. I think that the interconnectedness of it is the one thing that I wish that every engineer understood about One Health, because I think that we have a tendency, especially in academia, to kind of silo our knowledge, right? So we've got the vet school at the south end of campus, and the vet school keeps all of their veterinary knowledge here, and we've got a school of public health over here, and we've got engineering over here. And we do a really bad job of really cross-talking across these different silos. And so I think just recognizing how interconnected everything is, and there's nothing that gets done just in the environmental space that doesn't also impact health, at the human level, at the animal level, and then at those multiple dimensions of animal level, right? Because it's companion animals, it's wildlife, and it's also our domesticated species. So I think that would be the one thing that I wish that we could do a better job of communicating, just how interconnected it all is. We're not just our own nerds in our own silos, but that we actually impact each other as well. Did you have a question? That was this question? All right, so do you have any more questions? All right, well, you can reach me via email. I'm also on Twitter, and I'll be here for the next 5 or 10 minutes or so if you have any other questions. And thank you.